Well, hi, I'm Sirjhun. I'm an Ophthalmology Registrar, ST7, and today you'll be joining me on my day on the high volume list where I'm doing 30 cataracts, and we've been recording everything throughout the day and taking some interviews from some people, so fingers crossed it goes well. Alright, so we're here at Ninewells Hospital in Dundee, and we'll just get ahead in and get the list started. I started doing the high volume list maybe, I want to say about six to 8 months ago, something like that, and yeah, it's been great. I've slowly built up the numbers, and today hopefully we'll show you how we do it, how it's done, and yeah, we'll kind of take things from there. So
my name is John Ellis. I'm a consultant ophthalmologist in Ninewells. My wife and I moved to Ninewells in 1994, so I've been here for nigh on 30 years, really. But the thing that's relevant to this is that I left Dundee somewhat early in the pandemic to work in Glasgow, and came back to the appointment, which is for high volume surgery, in February 2022. So I've really been here officially for just over a year. But let me start the story a bit further back. We've had a mismatch growing between the elderly population, that is to say the over 60s, and the number of ophthalmologists in training who can provide the care that we're thinking of. In the case of cataract surgery, that is clearly going to be a technocratic service as well as a clinical one. And you need a lot of training to deliver that service safely. So that was a problem brewing long before COVID came along, due to the human resource mismatch with patients, and the growing need was exacerbated by a paradox that you need to be aware of, which is that surgical results were getting better and better, so people were getting surgery earlier and earlier, and it seems unethical to deprive people of a genuine clinical good once we know that that is safe and easy enough to deliver. So the numbers were beginning to climb, and then COVID came along, and quite rightly the health service had to provide life and limb saving surgeries and clinical services. And the planned patient care stuff inevitably got pushed forward. And there's been this phrase, the bow wave of blindness. If you picture a large ship pushing forward, there's this bow wave that's being pushed forward, and it still needs to be dealt with, but it was pushed into 2023, which is where we are now.
we've got a nice section of scrubs. Apologies, I'm not sure how iron they're going to be, but we'll just have to go with what we've got today. All right, so we're ready to go. So let's head back into theatre. We're going that way, okay?
Exactly.
Come on, boss.
We're not here.
You're not here? Okay. Good morning, good morning. So I guess first things, welcome. I know we've got a lot of guests here, so hello everyone. So yeah, so all topical as usual, just going down the list. So what I'll do, because
Hi, my name's Debbie, so I'm the charge nurse on ward 25. We have a huddle, so we go over the patients in each of them and make sure if they're needing extra biometry, if they're needing a bed round, if they need a chair. So then we're organised so that we can keep the flow going. One in the chair, one goes around the theatre, and then we keep going, swapping over patients, so it works that way. So it makes it much quicker as well.
Jumping down to patient number 7, so I'll get iris hook in each eye, so high myop again, and I'll go for soft shells, just a viscope please. Number 8 for iris hooks. These are just top of the waiting list cataracts, so they're not kind of cherry picked. Actually, that's not completely true. Dr. Ellis takes off posterior polar cataracts on my high volume list. This thing is going to be quite difficult, so just to let you guys know about that. We'll go for vision blue, go for heavy small pupil cases, traumatic cases, extremely dense cataracts. I actually learned how to do SICS on the high volume list because it's something I wanted to learn. And last but not least, it's going all the way to our last patient, just for vision blue and for viscope, please. It's a list which is exciting but also pretty tough going. Initially that was quite daunting, but you become efficient. Putting in iris hooks for me now you know, it takes an extra minute per hook. That's what I kind of think about in my head when I'm working things out. I don't hesitate if it needs to be done. I do that to have the best outcome for the patient. Okay, so probably one of the most important parts of the list is the playlist, and I've got my fake and Ninewells playlist here, as you can see. That's a picture from when I did my 1000 cataract, and it will keep us all entertained, starting off with a bit of chili. So let's do this today. We've got quite a few visitors here today, as you probably saw, which I have to say I'm slightly nervous about. I don't know about you. It just happens to be on the table. Maybe.
It's a truism perhaps, but the surgical time and the turnaround time ratio is, if you were a production engineer and you looked at it, you would say there's something funny about this. It just doesn't seem efficient. It's clear that the amount of time spent delivering the care that you want is a very small proportion of the overall patient journey. So clearly there's some low-hanging fruit in terms of things that you could change to deliver more actionable time for the patient journey. And when we looked at that, we thought, well, given the time we have, which is an 8-hour working day, we reckon we could get up to 24 patients without any sacrifice of safety. And in fact, there's data to show, really robust data to show that safety goes up as your numbers go up. It's a craft skill, and the more you do, the better you get. And a high-functioning team that understand one another, and surgeons who are constantly in action mode, so to speak, deliver far fewer complications. And that is robust, editorially chosen, scientifically validated information out in the public sphere. So there's no question about that.
So you'll feel a little bit of water every now and then. That's absolutely fine. Otherwise, I just want you to look straight at the lights for me if you can.
I'm Whitney, and I am the charge nurse here in Ninewells Eye Theatre.
Any pain or discomfort, just give us a little squeeze of the hand, okay?
At the end of 2021, met with Dr. Ellis and senior charge nurse from the ward, and Steph, one of my scrub nurses, we all had a meeting about starting a high volume list with Dr. Ellis.
Thank you very much.
So we had to have a look at the patient journey in its entirety and how we could eliminate wasted time, basically. And we spoke about doing 24 at that initial time.
And I think what fascinated me about the motivation behind the nursing team that I met here was the persuasion that we could be doing more without compromise of quality. So that kind of broke open speculation.
All right, you're doing really well. So the cataract's all away. We're just popping the lens in now. Just a few more minutes to go, and that'll be us. So nice and still.
One of the most important things was that you had staff engagement in it. So Dr. Ellis was very conscious of the fact that he wanted everybody's ideas, that it wasn't just his idea and we just did what he said. So the majority of the ideas that we're doing now have come from the nursing staff or theatre support workers.
Thank you.
And the surgeon, considered in the classical sense, is not the most important part of this entire journey, not at all. The surgeon, in a sense, is freed up to do a good job to the degree that stress is taken off and that the actual moment is highly concentrated. And for that to happen, you have to have a nursing team who can almost read minds. And I would contend in Dundee, they do read minds, which is very, very frightening for me. I repeatedly say it, and I say it because it's true, that the entire story here in Dundee is really a nursing success story.
We've done the first side of the patient, and when we go for the second eye and bilateral, we re-scrub again, scrub nurse goes out, and new scrub nurse comes in with new equipment. So we essentially treat it as a separate case completely to reduce the chance of infection. That's what a lot of the studies are showing. You know, the risk of infection is no different to doing one eye. So I think that's a huge change which has allowed us to do more cases during the high volume list. There's lots of benefits for the patient as well, and for the wider community in terms of the patient having to travel, the optometrist reviewing, reducing that, the carbon footprint of the patient coming to multiple appointments. So all in all, I think in the long term and looking at the bigger picture, it's certainly very advantageous. And I guess you know exactly what to expect this time.
We had a nursing team who, when we came with some of these ideas, it was like fertile soil. They were absolutely signed up to doing what we thought would be possible. And in fact, I hinted earlier that we overreached. They massively exceeded my expectations. So when we talked about scaling up slowly, the actual scale up happened far faster than I'd anticipated.
When one case is on, when the case is on, you will have your second team in here setting up all your tray. Okay? Once we're finished, we come, and this has been cleaned down, we come out. All of our team sit on the left-hand side. We don't swap sides, so the machine stays on one side and we stay on one side. Gives us easy access to the disposal room. And then once we're finished, our dirty tray and things, we have a person who is in the back here who cleans through our handpieces, puts our tray out the back, all our rubbish, and we come back out with our trolley back down and clean out.
Awesome. Good job. Thank you. Yeah, again with Whitney, I won't really say much apart from thank you. Thank you.
Your second is in shot.
Thank you. Thank you. Thank you.
It's a 21.5. Fiscal.
Thank you.
Thank you.
Great, well done. That's the operation all finished. You did really well there. All went absolutely fine. Having a little coffee break. There's Whitney and Pam's our leader today. So how many cataracts have we done so far?
We've done 4 bilaterals, 8 eyes.
And it's what, 10:30?
Yes, 10:32.
That's very precise. So we got a nice 15-minute coffee break.
Just flash your Patel Tartan.
So yeah, so I was asked about this. So basically, this hat was made by Dr. Cobb. So thank you very much, Dr. Cobb. And this is actually a tartan, which is a Patel clan tartan, and you can see there she handmade it for me as one of my gifts for when I go to Canada, and she's made a few for me actually. But yeah, very nicely done by my glaucoma consultant. So thank you very much, Dr. Cobb, for that. We're putting it to good use. So yeah, kind of custom made.
How often do you wash it?
So basically, it depends. If I'm doing high volume, then after every 12 cases, I give a quick rinse, dry.
Is that because you sweat a lot?
Yeah, because I sweat a lot, obviously. It depends on what case it is. Yeah, at least.
So I'm Lisa, I'm the Senior Charge Nurse in Ophthalmology, so cover Ward 25 as well as up in Area 6A, the eye clinic. They'll get their notes on the table beside it and with their drops. Patients that are independent and able to mobilise independently, they will walk around the theatre with a nurse. Patients that aren't as mobile will take them around on a porter's chair just like this. Nurses just take them around themselves. Coming back from theatre, everybody gets brought back in a chair for safety reasons.
I'm Bridget. I'm a staff nurse here in Ward 25, the Ophthalmology department. Prior to discharge, we will ensure that we explain how to administer post-operative drops and also talk to you about some post-operative care and some do's and don'ts following cataract procedure.
So our patients will come sit in our seat here, and our theatre staff will clerk them in, make sure that their checklist, their consent and biometry, everything is there and ready to go. And then the patient will be directed through here into theatre. A chair sitting outside here where the patient sits and waits until it's basically their turn to go into surgery. The patient care nurse will go and get their lens, have the consent open for the doctor in case he wants to speak to them about anything. And then when it's their turn to go, then we will come into theatre.
Just fierce teamwork and communication. I think the team are just excellent. Scrub nurses and the nursing team and theatre team, they are very helpful. Everyone's very accommodating, and it's quite fun as well. We're quite playful. I think everyone gets on. I think that makes the day quite enjoyable as well. Did you say the migraine joke?
I didn't. So I say my dream, you say your dream.
So you say his.
Your dream.
Here's your drain, and I say, oh, it's my drain. and then you say something. Oh, I've forgotten it. We should have wrote it down. We wrote a really well, like an amazing joke for the visitors, but they've all left now. I'm trying to remember what it is now.
The one thing I'll say is you just need to laugh at any jokes anybody makes. Make sure that everybody's happy.
So what you would say is, you would say, here's your migraine, and I would say, my drain or your drain? And you'd say, well, now it's your drain. And I would say, okay. Then we wait for the applause. What do you think? So we go for that? Yeah, okay.
I thought I was to say your drain, you meant my drain. Well, yeah, it is there.
Oh, yeah. This video is not sponsored by my drain.
We have great interaction. That's what I think one of the biggest successes of it is that because we work together so much, we know everybody's weaknesses, their strengths, and the way that we staff it then is important. It's obviously a very serious environment, we're doing an operation, but the camaraderie between the team, between the doctors and nurses and everybody just creates a really, really pleasant environment to work in.
I'm Gillian Christie and I'm a charge nurse in the eye theatres in Ninewells. Dr. Ellis has always said, you know, he's got the Venn diagram, you know, and the last thing that nobody would get is playfulness, and the patients are involved in this as well. They're involved in it and it just makes the day go a lot quicker, and it depends on your team as well. You know, you have to have the right team, and every person in that team needs to be engaged and wanting to be in there to do it, and big part of it.
Is it recording? So we operate without shoes on, so it's very important that you have very snazzy socks on, but Pam is just trying to outdo me there with her shoes and socks. Let's have a look at your socks as well. That's pretty, just showing off there.
1, 2, 3, 4.
Well done, that's the operation all finished, all went absolutely fine. You did really well there. Sorry, just try and relax for me. I'm just going to take that clip out of the eye. Good, well done. Okay. So it's lunchtime now. We've done, how many cases have we done? We've done 20 cases, which is, and all went all fine. A few tricky ones took a bit longer, but all in all going fine. We've got another 6 bilaterals to go, so 12 cases. And it looks as though all the patients are ready, which is good, so we'll just walk by.
To be drilled down to real specifics, there were 7 innovations that we made, 4 of which, the top 4 on the list, were nursing suggestions. They came not from me, but from the nursing team, and they have been phenomenally effective at unlocking capacity and speeding things.
Definitely the patients coming in batches. So initially on other lists you could have them coming in half-hour intervals, and if you have a patient that's cancelled, delayed, then you've got dead theatre space. Whereas if you've got 6 patients coming in at the one time, then surgeon can go around and see them if they need to be consented, and if somebody's running late, then you've always got a buffer of having another patient there, because if you're doing 24, you can't have any wasted time.
Indeed, and we've had quite a few visitors today, but a lot of them are gone now, thankfully. I have to be honest, I was quite nervous with 9 visitors coming. So I think we had some of our colleagues, fellow ophthalmologists and nursing team and ward staff and other clinicians from Edinburgh. I think they're just interested to see how things work and whether they can employ any of the things that we do here. And yeah, it was good. It was good to see them, but yeah, it's quite nerve-wracking having a few consultants watch you operate. But I think they're mainly looking at the system really, as opposed to me operating, so I can't say too much.
My name's Lisa Taylor. I'm a medical secretary here in Ophthalmology, and I work for, one of the consultants I work for is Dr. Ellis, who does the high volume cataract lists. So obviously if we've got 16 patients, we'd slot them in at different slots. So like we would have 4 at 8 o'clock, 4 at 10 o'clock, 4 at 12 and 4 at 2. And then if I've got any allowances, then it means then we can add in extras.
I think we'll start the second part of the list about 2 o'clock. And we've got 6 bilaterals to do. So, I mean, for me, that is 3 hours. So hopefully we'll finish at 5 o'clock on the dot. That's the plan.
The other being that we have 2 jump seats sitting out in our anaesthetic room, so that there's always a patient sitting out there ready to come in to theatre, because having patients going back and forward to the ward on trolleys, by the time you've got that patient back and you get your next one, the operation is going to be over, and again you would have a sort of delay between getting your next patient in. So that's again been a crucial time-saving thing.
We also reduced the preoperative dilating drops to a minimum of 1, and then during the operation, very early on in the procedure, we use an intraocular drug to dilate the pupil, and that has the advantage of immediate effect. And if a patient arrives late, they can be around in theatre very quickly. We no longer undress and put on a hospital gown. People come in their normal day clothes and normal shoes. So these are the kind of measures that the nursing team suggested that have unlocked capacity. And really, those are probably the dominant things that have changed things for us. And they're very simple measures. None of those cost anything, really.
So one thing I have not asked and talked about is how many staff do you have in theatre staff for high volume? Just so we.
One theatre, we have 7.
7. And so how many scrub nurses and how many healthcares and?
So it can be a mix. Ideally, you want to have 3 scrub nurses. 2 obviously are scrubbing. 3rd one does patient care, but she's also in charge of the list.
Okay.
And then the rest are the other 4 are healthcare assistants.
Sure. Okay. There you are. Awesome. Thank you very much. Thank you. Before the day of the list, actually a lot of work goes in beforehand, and not only the way appointments go out and the way that patients are contacted and the biometries, but I guess from my perspective, going through all the notes beforehand, all the notes are gone through beforehand, and we jot down if there's any challenges that we might kind of come across, or any risk factors, which might mean we need extra equipment or adjuncts during surgery. It means that we're prepared. We talk about it in the huddle in the morning.
So I'm Alison Simpson. I'm information manager here in ophthalmology. We've got a great team here in Ninewells, and I think basically everyone works together. And when you go and ask people, we put the idea to them, and no one ever says no. We say, well, let's try it. Let's see how it goes. We'll do 50 patients to begin with, and it's just been amazing. It's a team effort from everybody. Obviously I'm in charge of admin team, from my staff, all my staff, from getting extra case records in, preparing the notes, making appointments, same for reception staff when the patients come in the ward. The nursing staff have got a routine that they've, quick throughput, and it has been very much a really big team effort, and everyone is so excited about it, how we can get our waiting list down. And hopefully by the end of that we should be back to, about a 6-week wait for surgery, which is what we dream of again, which was pre-pandemic anyway, but it was,
It's, you don't really feel it.
So 24 was a kind of magic number which just looked about right, and we started to aim at that, but we kind of overshot, which is just a matter of interest. On the most busy days, when the dominant patient list has been bilateral, we have done 35 in a day, without undue stress and finishing on time without overruns. So that's certainly looking at the art of the possible. Running an operating theatre, as everyone would intuit, is not an easy thing to do, and in fact it costs £25 a minute to run a theatre. So if you waste 3 minutes, that's £75 wasted. So we've had the philosophy in the high volume that every minute is a reluctant captive, and we never squander them. So on a day of 32 cases, clearly if you lost 2 minutes per case, that's an hour lost. So we've taken this rule of procedure, which we've stolen really from David Brailsford from the Sky cycling team. It's the gradual accumulation of marginal gains.
Oh, we're absolutely fine. No problem. Okay, so that's us finished the list there today. It's been a busy day, but it's been good. It's 5:15 and we did 30 cataracts today in the high volume list. Really good list, and hopefully from this video you've had a chance to see kind of what it involves. I feel is that's probably the main thing. I think that's why I wanted to make this film really. I think if you were outlooker from maybe someone non-medical and looking at the department of them doing a high volume list, I think the common misconception would be like, okay, the most important thing is the surgeon, and then it's, you know, the staff, and then it's, you know, the system and the culture. But it's actually, I think I want to turn that on its head completely. I think it's really the culture here is, you know, one of the main reasons why people are motivated. They have the same vision, and then it's the system. You know, I think people have thought about it a lot, about how to be more efficient, and because of the vision, they are open to trying new things, and that enables the surgeon who's at, you know, at the bottom. You know, obviously it's important, but they are just given the opportunity just to operate and completely focus on what they need to be doing. And I'm a registrar doing the high volume list. I think that's to show that it's really the system and the culture here at Dundee which kind of enables it to happen, really. The other thing to mention, you know, I guess for other departments, especially at the visitors, I think the thing to remember is that you know, certainly for me, I didn't start at 30 cataracts. I started at 18, worked at 20, 22, 24 and 28 from there. And I guess it's just to recognise that it's a process more than anything.
So the thing is, we're not trying to change practice so much as changing culture. Changing culture normally takes a generation, and that's exactly the kind of lens that we're trying to look at this through. So we're trying to take registrars and trainees through who will consider high volume normative. And then obviously when they go on to substantive posts, consultants elsewhere, they will want to do surgery in this fashion. And I have to say, against the charge of hubris, that is actually the case, that registrars and teams now who do the high volume prefer it to other forms of working. And I think trainees in the East Coast have enjoyed it. Coming towards the end of this year, we may be able to offer up a training post in high volume surgery to the whole of Scotland for registrars from other areas to come and enjoy that or learn that. And then it'll just be a question of seeing whether that can cascade out into practice more widely, really.
Really good day. Lots of cases done today. All went pretty smoothly. A few tricky cases, but such as every day in the high volume cataract list, you've got to be prepared for that. Yeah, I very much appreciate being part of it. I think it's a great thing they're doing, and I hope that it will inspire more people, you know, inspire people in the ophthalmology community, or perhaps maybe just generate some discussion, you know, provoke some people to think about the culture of the way they're practicing. You know, can they address or could they try any of the things that we're doing? You know, for me, starting the high volume, there was lots of support. And, you know, it was lots of ups and downs, really. I mean, I started doing the high volume list kind of last year and was going quite well. I got my fellowship in Toronto in Canada, being directed by ICAMED, which, you know, I couldn't have done without their support. And, you know, amongst that as well, there was some very, you know, some lows afterwards as well. And I guess going through what I can only describe as a parent's worst nightmare. And I think when you go through loss, the support around you really do, you know, mean a huge amount. And I was worried about even without Karen operating at one point. And I think because of them, they've really just gently helped me get back into it. So yeah, just to say thank you to them. You know, I think it's been a crazy 7 years, and I couldn't have done it without them. I'm grateful that I was part of it.
Hello, Serge.
Hi.
How are things going?
Yeah, not too bad, thank you very much. So, yeah, it's okay. I've been doing a lot of filming, which is fun.
Good, good.
People have, some people have been quite keen, some people not so keen. So, hi Bridget, how are you?
I'm fine, thank you, doctor.
So, tell me how you involved in the high volume list.
Well.
Are you involved in the high volume list, Whitney? This is hitting the blooper reel, you know.
I mean,
honestly.
What should we do in that volume list, Julian?
Another important thing obviously is the playlist that we choose. So I've got my own fake and IOL playlist, and I'm pretty sure if you ask any of the theatre staff, they'll say that it's one of the best, I would say. So that's probably the second most important thing. I mean, that will probably make it.
Hello.
Hi Lisa, how are you?
Good, thank you.
I'm getting that.
I didn't even shake my hand. It's like that.
Great. Awesome, I think that's alright. Cringe.
Oh, no bother.
And you know, Lisa's been helping me out from the first video
I
we made.
know, yeah.
I've been harassing her since day one.
And I'm still as nervous.
She's
Yeah. I know, it's nice that I could wear a mask, cover my face.
So there's our camera woman, Sarah, thank you very much. So I think we're good to go. Get the list started.
Okay.
How tan do you want to be? so this is basically Scott. The cameraman behind you today, he did his 3rd cataract today, so well done, Umka. Did your 3rd cataract, well done. How do you feel?
Yeah, no, it's really good. Maybe one day can achieve the levels that Sirjhun, but no, it's all good.
And there's our other cameraman just coming up now. See you later, thanks for your help, bye.
Are you right there? Okay. You want to get in the film or?
I was going like that. Is it on? No.
Yeah, it's on now.
Oh. I'll tell you in a minute.
You know, different surgeons have got their own music playlists. And have you got a particular favourite or any playlist that stand out for you at all that you thought was worthwhile mentioning?
Well, Dr. Well, we'll start that one again. Now, Dr. Patel, your playlist is just upbeat, it's, you know, it's fantastic, and that is something for everyone, yes.
And something for no one at the same time.
Well,
yeah.
Yeah. Otherwise, I hope you enjoyed. Take care. Namaste.